My name's Elizabeth Gaynor Lloyd. My home address is 16 Pebworth Road, Harrow, HA13UD. I haven't really got a lot of list of current posts, but I am at the moment a member of the Eden Committee, the Equality, Diversity and Engagement Committee of Brent CCG, and he's my husband.
You may now speak.
Yes. Come on.
Oh, sorry.
Yes,
sorry.
Thank you.
Which have I got to do?
Right, I was going to start with, this is my wife. Okay, I'm Keith Perrin, I'm a councillor in Brent. I'm not here in that capacity, I'm here as a concerned resident who's been involved in healthcare with my wife. I'm chair of Wembley Locality PPG. I'm chair of the Sudbury Surgery PPG. I'm on their board as well as the CIC, as patient rep. I'm a member of the Northwick Park Arthritis Clinic PPG. Other bits and pieces that would be of use to you is I applied to be the lay member on the CCG about 2 years ago. And I remember one of the questions was, what would you tell the public about the closure of Central Middlesex? I said I'd tell the truth, which you can question me on later if you wish. I've had experience in the borough, in the third sector, running a daycare centre for the elderly, helping with a charity, learning disabilities for a couple of years, and after leaving Barclays Bank in '98, I worked in a IT training charity, providing IT training to long-term unemployed within the borough. So I think I've got a feel for.
Can I just confirm with Mrs. Lloyd that you were also a non-executive director of Hammersmith Park Hospital in the 1990s?
Yeah.
That's you, sorry.
Yes, I was.
And a shadow director of a local GP surgery in 2003.
Correct, and I was also a community director of Health Watch Brent for a while.
Thank you. So, am I also right that you also have patient connections, if you like? I think it's within terms of the rheumatoid services.
Yes, my husband's a rheumatoid arthritis sufferer, and I'm actually also, I just didn't run through everything that Keith did. I'm on the same arthritis patient panel and the PPGs.
Yeah. I missed one off, which you might want to pick up. I applied and was successful to become the representative for people with long-term conditions in the borough. I applied to the CCG on the Eden Committee and was accepted.
So is it fair to say that you both come to these issues with quite a number of different perspectives? I wonder if I might just ask if you could give the Commission your perspective on the demise of the Eden Committee following the report by Angela Coulter.
Do you want to do that? Or shall I? Okay. We thought that it was quite a lot of money to pay because they spent £50,000 on Dr. Coulter and her associate. Essentially, it's probably a little unfair, but to abolish us. The Eden Committee were classed as malfunctioning. I think what really happened was that it was very unfortunate that when we came into it, we suddenly discovered there was this proposal to tender out musculoskeletal services. Keith's mentioned that he's the long-term conditions, and we suddenly saw, in fact it was exactly 2 years ago because we were away and I was reading the Eden papers as you do when you're having a nice holiday, and right at the back it said in July they were going to have a consultation on the recommissioning of the musculoskeletal. So we sort of leapt out of our respective chairs, and insofar as he can with his disability, and we immediately went back and said, why didn't we know anything about this recommissioning? So that then meant that immediately we were going to the next Eden Committee with our colleagues and talking about this recommissioning that was taking place. In fact, we found out that they'd already decommissioned the services from Northwick Park, from London North West Hospital, without any consultation, certainly with a long-term conditions patient who actually suffers from one of the conditions that they were going to be tendering. So in a lot of ways that made it quite unfortunate because we got into quite a lot of challenge when we went to the CCG committees, and I have to speak very highly about the Eden Committee because I think the Brent CCG did a very good job in trying to set up this Equality, Diversity and Engagement Committee. They had the elected chairs of the 5 locality patient participation groups, and they had, is it 5 community
Yes.
8, right. So the elderly, I can't remember them all, elderly long-term conditions, Anne's one for, I think, yes, children. There are lots, I can't remember all the categories. But, and all those people were interviewed and they used a proper procurement process to appoint them. Everybody was a volunteer, but on the face of it, it was set up in a very good way to bring representatives on board, to essentially for them to bring their commissioning strategies and use them as a sounding board and all other things. But I think it probably fell apart because we ended up being horribly involved in discussing the first, as we were starting to discover this procurement procedure and challenging. And there was a lot of, but you haven't engaged properly. Peter, of course, with his legal background, we started analysing that they hadn't complied with Section 14Z2. And that, in a lot of ways, I think actually has had some quite good effects, but it did mean that suddenly there was an atmosphere of challenge because this committee was set up and almost the only people who could vote on it were patients, and there were a lot of us. So that meant it had a real voice and it was a formal part of CCG. But it had the downside that some of the community representatives, I think, started to think that there were a load of old crazies on this committee who just never shut up about the defects in procedure. So in a way, it was good, and in another way, I can see why people marked us as dysfunctional. But all I would say is that everything, as I think Robin has said before, that we said to them 2 years ago about what they were doing wrong with the MSK procurement, I believe has been sort of shown to have been slightly why they abandoned it. That may be a bit unfair, but I'm sure it's got a lot to do with it.
I'll come back to that in a moment if we may. I just wanted to ask you, just touched on this very briefly, in terms of the out-of-hospital strategies. You raised that you suggest it was a failure of the CCG to comply with its statutory duty. Do I understand it correctly that the duty is one-off public consultation, patient consultation? I always defer to my colleague over there on exactly what the duties are under Section 14Z2, because we did actually go to the Ombudsman, or one patient went to the Ombudsman about what they were doing. In fact, they had to reset the way they were doing the consultations. Now, you express, and this is at page 807 of your and it's really at the bottom, it's the last paragraph, you express concern that there's a poor working relationship between the London North West Healthcare Trust and Brent CCG, and you express concerns about how that might affect the commissioning process. Can you expand on that? We attend a lot of it's a very sad life, really. I attend a lot of CCG meetings as a result of this Eden Committee, and sometimes when they were talking on the board about the hospital, you would think that they were the enemy. I come to the conclusion that a lot of it has got to do with the money side, because the CCGs are busy trying to push down the cost of everything. And of course, as far as I learnt these expressions about the hospital is overperforming, we never really knew what that meant. But I think what it means is that they are doing more than somebody estimated they were going to do, and so the CCG were having to pay them more. So it was not good, really, because you sit in the meeting and think, this is funny, because for most patients, although you know everybody has a quarrel, you'll know people who've had a bad experience at the hospital or whatever, but for most people we say this is our local hospital, and it seems a bit odd to hear it being spoken about as the enemy. Then, and I think I quoted a couple of things because, again, a sad person, I read a lot of board minutes, and you read one of the quotes that I put in earlier that had actually come from executive committee minutes, and there was another one. Also, I think you'll find that as well as in the Brent PPG, just for your reference, it's also at page 811 of this document. Okay.
Well, there was another one, certainly, I don't know whether I sent both of them in, but there was another one about we really, until they improve, we don't want to do any more business with them, which worried me. But having said that, it was interesting because I went to the London North West Healthcare's last Trust Board meeting, and it was quite interesting that the Chief Operating Officer said that they'd seen a sort of a sea change with the CCG in the latest negotiating round. And it looks as though maybe, and I mean, it's terrible because it sounds as though we think it's because of the battles we've had over musculoskeletal, but certainly I got the impression that they thought they were having a better negotiating round. But certainly it worried me that in their open conversations at board meetings and in the evidenced papers that we looked at, there seemed to be an attitude of, you know, of sort of not a very good relationship.
Can I ask you to turn on to something you deal with at page 810, and it's at paragraph 213. Reference is made to you pursuing freedom of information request plural in relation to the cost of the wave one bids.
Yes.
Can you update us with where you've got to on that?
Yes, mostly the cost on this relates to what I viewed as a subsidy that was paid to the successful bidder. The cardiology bid was a bit strange, and I go on about it a lot in detail, but it was the last two bidders, I understand it, were the London North West Healthcare Trust and Royal Free Hospital. And the Royal Free won the bid, and there were patients who were complaining about that, principally the community heart failure cohort. But I sort of got onto the back of it because, as you will see from the evidence, I got quite involved in looking at the costs of lift buildings, which are the responsibility of Brent CCG, and they are quite expensive. And so a throwaway remark in one of the meetings, and I'm sorry this is a bit involved, indicated that they were having some trouble in negotiating the lease to BMI, who are one of these other Wave 1 providers, and because of the lease was a problem because of costs. Well, because of my involvement for my own GPs who are in a lift building when I was the shadow director, I realised... I'm not quite sure. It's like PFI. It's something to... I think it's local something funding. But it's the same... effectively, it's just a different way of... But I think there was local authority involvement in it. Sorry. So, certainly, the problem with being in a PFI building, of course, is that the rents tend to be extremely high. And you've also got what can be an unlimited exposure to service charges and costs of, for instance, if you do alterations or anything, you have to get... let's call it the PFI provider to come and do it. So you want to put up a notice board and you've got to pay 150 quid or whatever. So you are immediately, if you enter into any kind of lease obligation on that, you are a bit worried because, you may have unlimited costs. So I thought, oh, that's interesting. I'll just ask a few FOI questions and make sure that, in fact, that there was no hidden subsidy. At first I got really worried because of the private sector provider, the BMI. I thought, well, I don't want the CCG subsidising their rent. But I asked about both, and I also said, and by the way, have you got to do any alterations? And of course the answer came back. Well, the answer about subsidy on rent is extremely difficult to follow. I can't really get to the bottom of it. But on alterations, what I regard as a subsidy was made because they had to modify these two lift premises in order to make them fit to be used in the case of community, certainly in the case of community cardiology rooms. So I suddenly discovered in a set of minutes that in a QIP committee, somebody had said, oh, we've got to pay, but we're going to have to fund this. It was something short of $500,000 to do these alterations. So that was in the QIP committee, and then that was the payment of that money was resolved by chair's action. So I immediately thought, well, A, this isn't very transparent, but B, far more putting my commercial hat on. In the commercial sector, if you do a tender and you win on it, then you don't suddenly lob another $500,000 to the successful provider, in my opinion. So I raised that, and with Monitor, who already had a complaint, somebody referred to it earlier, and I've just heard from Monitor that they're definitely not going to bother taking it up because it's too small and they haven't really got the resources to be dealing with all this.
We have some breath of time. Thank you. So
sorry.
I ask that we cut to the MS case.
Okay.
Clearly there's a wealth of information in your paper about it. So can I ask you just basically in this way, what's gone wrong? What's gone wrong with the procurement exercise? Can you help us with that?
Well, I think it took 2 years for a kick-off, and I think what they originally said they wanted to do was that they were going to procure all these waves of services by something called competitive dialogue, which, as I've said in the paper, I don't think is necessarily a good idea. But on MSK, they've had changes of personnel, haven't they? They've had dedicated teams coming along. They have involved stakeholder engagement groups. We've all put our halfpenn'orth in, and we expected that the bidders, when they all came in, the whole idea was that they would devising the service. Then we suddenly got notified. They got a new person who was advising them, who turned out to be a person who's quite a big proponent of the lead provider model. So everything slightly started to change. They said they were going to have it as a lead provider model. Now that means you've got, as far as I can ascertain, it means you've got one overall person who takes charge of the contract and then subcontracts everything out. Now Peter mentions the difficulty that had happened with other tenderings. Bedford's been a disaster, and also the coastal one has. But to me the more difficulty is that how does that affect if you've got ordinary provider trusts coming in as the ones who are going to do the bidding? They're not set up to be sort of overall themselves commissioners of services. They're there to provide them, not to actually say, oh dear, we've got to do this contract at a particular cost, and then we've got to find other people to do it underneath us. So that, I couldn't see, suddenly we seem to be lumping this lead provider model onto what was meant to be, get all these, if you agree with competitive dialogue and say, let's not design the service ourselves, but let's get somebody else to come in and do it, then I couldn't quite understand why we'd suddenly got the CCG saying it was lead provider model, but I suspect it's because they thought they could do a costs envelope, that they could say, here you are, you've got to do it all for this amount of money. But as to what went wrong, we think, because certainly the previous Chief Operating Officer, Joe Olsen, did say that they would pause once they'd got the initial impact assessment in, and see what they think. And I think with the weight of evidence with other difficult things around the country, I think they thought they weren't going to make the savings. I think they'd looked at the Wave 1 inputs where they'd found that the ophthalmology certainly wasn't getting the take-up. The cardiology has got major problems because they still, a few weeks ago, they still hadn't managed to get the Virgin telecommunications thing into one of the things, so they can't actually operate out of one of them. So, and I think that they have had big difficulties. I'm sure it is taking up a huge amount of time and resource for the CCG. In fact, there was one thing that the new senior responsible officer said when he arrived. He said, there are very few employees in the CCG. We can't give the resource that we're having to give to this. They have spent 2 years, an enormous amount of time, haven't they, on it? Yes,
I was just going to make one sort of overarching comment. Sorry. And that is, about a year ago, Joe Olsen actually said, quite openly, that the PPG chairs and Eden were too challenging. It was like being in court. And I put that on top of the challenges through the MSK SEG, same people again, and the Eden committee. Is that why they got rid of Eden? Is that why MSK's failed? Has it failed?
But
Okay.
The other thing that also strikes me is that, and somebody was saying, do you think this Shaping a Healthier Future can work? I think the biggest problem is, from the evidence that we've seen about doing these out-of-hospital services, they take an enormous amount of manpower. They mean they've got to have legal advisors, accountancy advisors, they have to bring in the commissioning support unit, just to do the procurement. And we're talking about, we've been very closely involved looking at 4 waves. The first 2 of which haven't been very successful, 2 they've abandoned. Hopefully they're going to get some good stuff out of the work that's been done. But can you imagine if you then spread that across all 8 CCGs, trying to do these out-of-hospital strategies? GPs are not trained to do all this sort of stuff. And that then combined with the other issue which we raised, which is massive conflicts of interest. Because again, we're not impugning any GPs, but we know that particular locality networks are bidding for these things as well, which is very difficult because they're the commissioners and they're the providers. So I think that is another thing that went wrong, because there was a very strong challenge from the PPG chairs saying, you must reveal your conflicts of interest. We got them to do their declarations of interest. As soon as they do, and the main clinical lead at the end, who was actually excellent, suddenly had to make a declaration of interest to us in a stakeholder engagement group. He sort of muttered, but he said, if my group win this job, I personally won't take any profit from the contract. Well, you sit there and think, this is ridiculous. We quite wanted him there because, in fact, his interventions in the stakeholder were really good and really practical, and we thought, if only he'd been talking, we probably wouldn't be here. But I think conflict of interest is very difficult for them, very difficult.
Thank you. I was going to ask about that anyway, but you've covered it very nicely. I just wanted to ask one final question. You talk on page 861 about the involvement of the Morton. I just wondered briefly, what's your take on their involvement, and do you think they're value for money?
Well, that's difficult. Well, I know that they were initially paid £71,000 to do the impact assessment and the consult. I do know that. I think they probably pull a template out of a drawer, because every time you see one of these things, they always say, you know, how far have you got to travel? Were you happy with what? Do you feel that people discussed properly with you? They seem to have a template of questions which don't really ever answer. How do you know, are you feeling better? Are you feeling as though you've been treated? I have to say that I think they slightly improved when they drilled down into the final bit of the impact assessment. Where they gave us, and more than just me, I mean, we had an hour-long discussion on the telephone going into what do you think are going to be the impacts of this? Can you see any advantages? Can you see any disadvantages? And they certainly fed them into the final impact assessment on MSK and gynecology, which I think, again, because the impact assessment when it was done was another thing that definitely contributed to them, as far as we know, to the CCG abandoning it. What do I think? Well, I was a commercial property solicitor. I remember Mott MacDonald as a lot of engineers. And I think what happened when they did PFI projects, I think they thought it was a jolly good thing to do consulting arms who would do public engagement. But I don't know what when they do their travel analysis, blimey, it's the same old thing, oh, that, you know, we can have the rating is... And they're totally meaningless, because they'll say some people from Harlesden can do that. They don't drill into the detail. Nobody bothers to say, we've got a demographic map here which shows, you know, where people suffer from these particular conditions. Let's actually look whether they're going to be better off travelling to Willesden Centre for Health and Care, where there's hardly any car parking, or whether they go to Northwick Park Hospital at the north end of the borough, or Central Middlesex at the other end of the borough. It's not really robust stuff at all, and I just think it's a box-ticking exercise, and the consultation was awful. They shoehorned a consultation on gynecology in with the consultation on MSK together in the same brochure, and they had road shows. They'd stand there, and I sort of stood behind one lady who was doing, and the girl just said, well, here you are, just read the booklet, and it's all about, you know, it's which hospital you go to. So she did, it was just, and then they forgot to collect a lot of the questionnaires that were actually specifically left at the arthritis centre.
I think, just quickly, the one at Northwick Park arthritis clinic, I actually turned up in the morning. Mott MacDonald didn't for a few days. They were doing something else.
But they did turn up in the end. But it probably only because Keith had phoned up and said, where are you?
Thank you. I have no further questions, but if you wait there may be some questions in the commission.
I remember it said on my mind. I described the earlier submission as a stiletto. I think yours is a hatchet. As I say, I'm not sure it's actually the beast is gone yet. Firstly, I'm almost embarrassed to ask this question. If I was, as a GP, if I was practicing in the area where you live, say under the auspices of Northwick Park, say, and I want to ask you, as an expert patient, as an arthritis sufferer, and say you called because you had a fever, and you're on your methotrexate or anti-TNF drugs, and I organised an urgent white cell count, and your white cell count's so low you've individually named the white cells. And I know you've got to go in because you've probably got septicemia. And the service has been commissioned out, and not supposed to have been commissioned away. Who do I ring?
Oh dear, that's a good one, this. Something very, very similar actually happened. If my service had been at Willesden or somewhere else like that, I'm not sure it'd actually be here. I had an operation on my hand, this one here, and it started to swell. And I went to see a nurse at the hospital. Said, no, that's fine, it should be like that. The next day I had my appointment with my consultant. He said, no, I've operated on you, it should be like that. The next day in Wembley, I was sort of falling on the floor almost with a large hand. I went to Wembley Mats, if anybody remembers that, which is a minor accident and trauma, okay, which is closed now and changed. And a young doctor there said, oh my dear, take these antibiotics straight away and go and see your GP. I did. Next day was my appointment at the arthritis clinic. I walked in, staggering almost, I suppose, and my specialist nurse said, "Oh my God, Keith, lie down on there." Within about 12 hours, I was on a drip. I think I probably wouldn't have made the day out without that. So, does that sort of answer your question?
This commission had gone through. I don't know where was it going to go to all three, or who else was going to manage?
Well, it might have gone. I mean, we don't know who all the providers were, but we do know that London North West were in a consortium. Oh, sorry. We don't know who all the three providers were, but we do know that one of them was a consortium of London North West, I think Imperial and Harness group of GPs.
So do you ring, I suppose after thinking about it, you ring the acute medical registrar of the...
I have a helpline for MSK, for the arthritis clinic, because I was on method.
Would that exist if it was decommissioned?
It would depend on how they redevise the service. Yes. What we could tell of the way they were redevising the service, they were they going to... No, it's because a lot of it is actually more directed back to the GP, interestingly. There's a lot of stuff about let's educate the GPs, let's make sure that you're back with the GPs.
I used to do a lot of disease monitoring disease-modifying agents.
DMARDs.
Years ago, we just did it. And it is scary.
Yes.
I can tell you, I would never have treated as septicemia. So you've got to go in and say, you've got to go in. And presumably, I know when this service was around for Charing Cross, which is the area I know, I could ring up the rheumatology registrar, or I could ring the acute medical registrar and call, knowing that an opinion while they're in under a different unit would have been taken from the rheumatologist. Because as you know, it's a very skilled business, knowing what dose to change, when to stop the disease-modifying agent, when to restart it.
Well, I regret to tell you that the DMARD service is now, it's just out with the GPs, and in fact part of one of the consultation things when Mott MacDonald listed a whole list of things with the GPs, they're very good, they put down everything, and one of them was, we don't think this DMARD monitoring is safe, and we know from our own acute provider that they are worried about the way that the monitoring's done, because they're still, I think in Brent, still using yellow cards, which we banged on about, saying, no, you must do the proper, so it's all linked in with the secondary care people.
I'm not against, I think GPs can monitor, as long as they've got the backup. And what I'm concerned about is that what are the routes of backup for a GP who's...
But it's fine if you're talking about educated patients. I don't mean that in a patronising way, but supposing nobody turns up with a yellow card, supposing they forget it, that's the worrying thing, because that's what we've always tried to do, is to speak for... It sounds terribly patronising, but for those who don't know all the issues and don't know the problems.
Again, I want to see your view as experts in the NHS. And you can hear it. I've got these bees, I keep talking about bees in my bonnet. But here I go again, about levers. And I just want to know, what are the levers of change? Where are they? And in fact, are there any levers of change? Or is it totally chaotic?
What, you mean to change the rolling on a...
change something.
You mean in this project?
You go as a patient, as an educated patient, as a representative of other patient groups. How does one make a real change, do you think?
Well,
do you go through your counsellors? Do you go to NHS England?
Well, we've tended to bang on at the CCG a lot, as you can gather, because they abolished us. So we carry on banging on as individuals now.
Do they have power? It seems to me that they have to appeal to rigid mechanisms.
I think they have a reasonable amount of power, NHS England are just... No, I won't say what I was going to say. We'd have appealed to NHS England. We did when we thought that we didn't like the way that the Brent CCG were going to change their constitution, basically as part of this getting rid of the Eden Committee. But I wouldn't say they're exactly... We were ushered off to their offices. We had a very nice time talking to them in their offices, and they were going to do lots of things, but they didn't. Yeah.
I don't think it'd give me any confidence.
Well, I don't know what... I mean, we just bang on, basically, and join up with a lot of other patient groups. It is, and I think
Where do you think the locus of power is in SHA?
I've no idea. I mean, and I do think there is the big flaw, I think, with this, with one of them, of SHAF or whatever we called it, is that it's founded on a basis, first of all, of shoving out these out-of-hospital strategies, which by our experience is such a difficult process for any of them to do, because they've got, apart from all the time it takes, they've got to comply with the competition rules. So as soon as they decide they're going to do one of these out-of-hospital services, they've got to do a supply to health tender, they've got to encourage everybody in. So there's all that. Then the other side of that, of course, is that they're saying, well, what we're going to do is we're going to do it through networks of doctors. Well, apart from the conflict of interest issue on that, my own experience through being on this shadow CIC taking over a doctor's practice is that doctors don't have a clue about corporate governance. They run their business. Yes, of course it's a small business, but the running of a business of a network, so for instance, you know, the networks are getting in Prime Minister's Challenge Fund funding. But and so they've set up this corporate body. So they've got this money in. But my experience is that I don't even know that they know how to run a board. You know, that there is corporate governance on a board. You sit there, you say, we've got this contract from the government, we've got to fulfil it. Now, whether GPs who are used to running their own businesses, whether they understand that means it's, so I think, how on earth are you ever going to implement these out-of-hospital strategies when you're dealing with competition law, just feisty patients? You've also got to consult. How do you do a real consultation? It's extremely difficult. Anne was saying about, you know, Anne, who's Brent Mencap, I always remember her saying to me, I haven't got 10 learning disabled people to pull out of a drawer for a consultation. You know, I feel sorry for them in a way, but if you factor that into shaping a healthy future, I don't see how anybody could ever put those out-of-hospital strategies in place. And I think the networks that I was at a presentation to Brent Pensioners Forum the other day where somebody said, well, you can really forget the idea of seeing your individual GP. And you can see why, because the message is coming, it's networks. We haven't got enough capacity, we'll have to do it through networks. But what worries me, and whole systems integrated care is the same. You won't be seeing your GP, you're going to be a complex patient managed through this multidisciplinary team. But then, of course, they say, of course, the social workers don't turn up because they haven't got any and we haven't got a district. But never mind, it's, you know, at least we try. And suddenly, and I'm probably rambling far too much, but I'm just trying to say, you can't implement the out-of-hospital strategies. You're never going to do it. It's going to cost a flipping fortune. If you want to comply with everything, you'll spend a very great deal of money on lawyers. You only have to look. We have persuaded the CCG to publish all their contracts over £25,000, and the money is eye-watering, most of which is going to McKinsey, I have to say it. And it's just eye-watering. There's no accountability as to what it's being spent on. So they bring the consultants, because I think the consultants come from a different budget from everything else they're doing, so they can bring these consultants in. But they spent £107,000 on a lot called public-private partnership. They advised on Wave 1. And I have to tell you that the Wave 1 tendering process that they advised on had to be abandoned because they'd done it all wrong. Sorry.
Thank you.
Oh, can I just say one thing about the shaping? Oh, I'm sorry. No, it's just because somebody's mentioned the PPRG for Shaping a Healthier Future. Now, when I was a community director for Healthwatch, I went along to some of those, and the original setup of those was that every CCG's lay member and every CCG's Healthwatch should send a representative. And the first meetings I went to, they were all there. And as Anne O'Neill said, we were running to catch up. We went. There were clearly some people who were well embedded in the process, knew exactly what they were talking about, and it was very intimidating. And that was an enormous process. And they also had terms of reference. There was an argument about whether it should be confidential. You said, well, hang on, if we're meant to be representing the patients, how can we make it confidential? But those minutes of, I mean, I know quite a lot about that, but I had confidentiality imposed on me. And that, to me, seemed absolutely mad. I was never absolutely able to establish that we had a Brent resident who was a representative on the travel advisory group. I still don't know whether there is. I keep asking. There may well be. We've put people forward. But if you have a patient participation group, you should be able to be saying what they are. The minutes should be available. There are loads of them. Loads and loads of them. But it's all confidential. So how do you get the feedback from patient representatives? So I just want to say that.
Well, maybe patient involvement group, as in one patient somewhere that's been involved that doesn't bother to tell anybody. But I think you're painting a vivid picture here, as others have, of a bit of a shambles here. And I just wanted to basically say, you know, would you agree with the idea that maybe the GPs are out of their depth in trying to actually make this work? And what would you, as campaigners, think would be a way out of this? Because we appear to be locked into this scenario now where, you know, people are passing responsibilities from one side to the other. You've got management consultants come in with whiz-kid ideas that nobody quite understands and can't quite implement. So how would you suggest, you know, we need to make some recommendations from our report? I mean, what would be a more rational way of doing it?
Well, it's like that joke about I wouldn't have started from here. Not all GPs engage. Some are engaged for purposes that may possibly be more also to do with their pocket as well. It's the same old thing. I wish somebody was actually planning it. If I believed that somebody was planning it, I'd be a lot. But I don't see any evidence. When Mark Spencer was talking this morning and saying I'm not the financial person, it seemed to me to be absolutely crazy, because if you're in charge of the clinical side, you've got to know that you're going to have the money to deliver this. If you believe in the grand plan, you have to have the money. So the idea that nobody's actually worked out how much the money is seems a bit odd. So perhaps what I'd start about is try and find out what the real budget is. What are we actually being allowed for this transformation process? And somebody do what I used to have to do when I was at work and do a business plan and say, this is what it's going to cost me, this is how it's going to fit. And I would make the 8 CCGs allegedly working together, but there is absolutely no evidence that when, for instance, Brent decommissions MSK, that they've talked to Harrow. Are they doing the same thing? They actually once said they were waiting to hear from Harrow whether they wanted to do the same commissioning. And when we went to ask Harrow, because at Harrow you're allowed to ask questions, they said, we don't know anything about this thing that Brent are allegedly waiting for. So you need somebody who's really with a proper view about improving the health and to sit down and plan it properly and have a budget. But don't, for God's sake, leave it to all these different CCGs to go out and do their own different processes. And are they talking to each other? They say they are, but I don't know whether they are, because of course they're all trying to make their own quip savings. So as Rob and Varsha said, if Harrow are 11 million in deficit already and Brent have got 34, where's, and all of it is about money and savings. They call it quality innovation and all the other stuff, but it's money. It's money.
Can I interrupt you there?
Oh, I'm sorry.
No, thank you. I think you've answered the question. It's not been easy. Very helpful. I'm just mindful of the poor stenographer who's been typing now for over 7 hours. We've got 2 more people who need to speak. Everyone has to talk.
No, thank you.
Very, very useful.
Thank you. Thank you.